Welcome to the Clinicians Coffee Chat on Aging and Homelessness. I'm Lily Catalano, and I'm a project manager for the National Healthcare for the Homeless Council in Nashville. This project was supported by the Human Resources and Services Administration, HRSA, of the Department of Health and Human Services, HHS, under grant number U30CS09746, a national training and technical assistance cooperative agreement for $1,625,741 with 0% match from non-governmental sources. This information or content and conclusions are those of the presenters and should not be construed as the official policy or position of, nor should any endorsements be inferred by, HRSA, HHS, or the U.S. government. NHCHC is a nonpartisan, non-commercial organization. This is the last of a 4-part Coffee Chat series, though we will start another 4-part series on diabetes in the coming months. We call them Coffee Chats because they are informal conversations. We invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for us all to share questions, ideas, challenges, and support for each other. We have a large group of people participating today, and one of the best parts of the Coffee Chats is getting to hear from people doing this type of work from all across the country. This series was developed by the Healthcare for the Homeless Clinicians Network, which is the nation's largest network of providers of hands-on care to people who are homeless. The network helps members connect, learn from each other, and share best practices across the homeless healthcare field. If you're not already a member of the Clinicians Network, please join for free via the link in the web links box on your screen. The Clinicians Network also has a Facebook group open to its members, and that's a place to ask questions and share successes and challenges as well. Colleagues from across the country share their expertise and experience and engage together on issues related to health and homelessness. You can join that group today, also via the link in the web link pod on your screen. Now, some instructions about how you can engage during the chat today. We want to hear from you, and we welcome your questions and stories throughout the chat. The more you all engage, the better the chat will be. You can type directly into the attendee chat pod on the top right corner of your screen. Your comments will show up to all participants, and I will try to refer comments and questions to the panelists as they come in. So first up, let's see who we've got participating in the room today. We're posting a poll question on the screen, and you can click your response right there. So what type of organization do you represent? Are you part of a Healthcare for the Homeless program, another health center, a shelter, or another service provider? It looks like we've got a real mix of organizations represented today. About a quarter from Healthcare for the Homeless programs, some more from other health centers, about 15% from shelters, and then about half from other service providers. Thank you. And then what about your current role at your organization? Are you primarily a clinician, an administrator, a government official? Do you do policy and advocacy work? Are you a consumer, or do you have another role? And it looks like we've got a number of clinicians and administrators, and also some government officials and policy and advocacy folks, and folks in another category. And then for our final poll question, how often do you encounter issues related to aging and homelessness in your work? Is this something you come across very frequently? Is it somewhat frequently, just occasionally, or almost never? And it looks like well over 80% of us are either encountering these issues frequently or very frequently. Great. Thank you so much for your responses. Before I introduce today's panelists, I want to point out a few relevant resources created by the National Healthcare for the Homeless Council that are available for you to download through the resources pod that's on your screen. You can see that we have an issue of In Focus, which synthesizes literature on homelessness among older and elderly adults in the U.S. You can also download the Adapted Clinical Guidelines on End-of-Life Care for people experiencing homelessness, and that includes samples of things like advanced directives for people experiencing homelessness and other things that we'll discuss today during the chat. The resource pod also includes a profile on aging in place and supportive housing, which the Council developed with the Corporation for Supportive Housing. And now I'm thrilled to introduce you to our panelists today. We have Lawanda Williams, Pia Valvassori, and Catherine Crosland. Welcome. I'm going to invite each of you to tell us a little bit about yourself before we get started with the questions.
Hello, everyone. My name is Lawanda Williams, and I work for Healthcare for the Homeless in Baltimore, Maryland, where I serve as the Director of Housing Services for a permanent supportive housing program that we have here at our center. We are a federally qualified health center here in the heart of Baltimore City.
Good afternoon, everybody. My name is Pia Valvassori. I'm from Orlando, Florida. I'm a clinician at the Healthcare Center for the Homeless and have a number of academic appointments where I teach on issues that pertain to healthcare for the homeless.
Hello, everyone. My name is Catherine Crosland, and I'm from Washington, D.C. I work for Unity Healthcare, which was originally Healthcare for the Homeless, Washington, D.C., and it is now a larger federally qualified health center, but we still have a number of sites that specifically serve people experiencing homelessness, and I help to manage those sites as a physician clinician.
Thank you all so much. Our format today is that I will start off with a question to the panelists and then open the question to all participants as well. You can type into the chat pod at any time. If you have follow-up questions or points that you'd like to share or new questions that you'd like the panelists to explore, type those in at any time too. So first up, what are some of the major issues that you all have encountered in working with clients who are aging and experiencing homelessness?
So this is Lawanda. So one of the things that we see in our community here, and I'm sure this may be similar in other places, but really looking at the lack of accessible units. As we strive to serve individuals who are aging, we know that our population tends to experience some of the challenges of older age and advanced age at much earlier points in time. So there's a lack of accessible units in our community. So as we're helping individuals to even explore housing options, oftentimes individuals who might be aging and having some of the disabilities that might come from being out on the street and living in homelessness for some time aren't really able to access some of those resources, and certainly being able to get into units that actually will promote their ability to age in place. So I think that's one of the, from a housing standpoint and serving individuals who had been formerly homeless and experiencing homelessness and trying to get into housing, that's one of the things we see quite a bit.
Hi, this is Pia from Orlando, and I think similar to Lawanda's experience, I think making modifications in terms of appropriate placement for people who are elderly and might have some physical disability and functional disabilities is a real challenge, in addition to providing whatever supportive services and perhaps durable medical equipment they may need. You know, and most recently we've had individuals who have had cognitive-related issues, And so getting those capacity evaluations done, working with them on advanced directives can really be a challenge.
Hi, this is Catherine, and I want to chime in with both of those. I think one thing I also see as a physician is a lot of our patients, I worry that they really just have a higher level of need in terms of the medical needs, and I wonder if some of our patients would be better served either in long-term nursing facilities or some kind of assisted living type setting where they have nurses passing medications and checking on them, preparing meals, that sort of thing, as well as, and if instead of that, sometimes in a scattered setting, having home health aides. And that can be challenging to get home health aides to a number of our patients. So looking at those kind of higher level of medical needs once people do get placed into housing.
Thank you. And I'd like to also invite any of our participants to go ahead and start typing in the attendee chat about what are the major issues that you encounter in your work. Catherine, you mentioned experiencing clients who have a need for assisted living or nursing services. What resources are available in your community for clients who may need those services?
So right now we have a significant shortage of nursing home beds, especially for our patient population, and it sounds like that may be similar in other places in the country. So that's something that I'm actively trying to work with our Interagency Council on Homelessness to advocate for more assisted living type beds for our aging homeless population, as well as more nursing home beds to be available to them. You know, let alone when they're in the shelters and the day centers that we have clinics based in. So I'm talking about, you know, the ideal situation when they get placed into housing, what kind of housing would be good for them. But the reality is a lot of our patients are have significant medical challenges, physical vulnerabilities, such as, you know, having experienced a stroke, and they're physically impaired, and they're really kind of getting by barely in shelters on the street. So we're working with those challenges. So we're advocating for more, but there's a definite shortage.
Thank you. Is that similar in Baltimore and Orlando?
Yeah, we see that in Baltimore for sure. I think one of the things, specifically as it relates to nursing homes, is that it really can be very challenging. I think there is a dearth of beds available, but I think the other thing that sort of contributes to there being the shortage is also, I think many nursing homes don't have the infrastructures built in to deal with the complexities of some of the clients that we work with. You know, most medical nursing home facilities, there are lots of paperwork, and it's very onerous to get someone in. Oftentimes, we might be working with individuals who might need nursing home placements, but they're actually not in the middle of a hospital episode. And so what we see here in Baltimore and in Maryland more broadly is that it can be a bit easier to get individuals into a nursing home, you know, depending on if they have Medicaid or Medicare, when they're in the middle of a hospitalization. But trying to do that from the community, with a client who's right in front of you and you've sort of acknowledged or recognized that there might be a need for placement, the process to do that is much more onerous. And I think once individuals get into nursing home placements, it can be really difficult because there's not robust mental health services within the structure of nursing homes and the way that they're set up here in our continuum. You really have not a lot of behavioral health support. While most nursing homes are required by license here, it's the Office of Healthcare Quality, and they do require there to be social services on site. A lot of that is based on bed size, and then also, you know, if you have, you know, less than 120 beds, you don't have to have a licensed social worker, and so there's some nuances with that, but certainly those are not behavioral health services. It's really more about helping people to acclimate to the nursing home setting, and discharge planning and those sorts of things. So I feel like oftentimes it can be difficult to get individuals into nursing homes because of the complexity. And sometimes we have some challenges with getting folks to accept our population because of that, or other behavioral health issues or criminal justice issues, even when there is a bed open.
I would second. I'm sorry. Go ahead, Tia.
Yeah, go ahead, Tia. This is Tia from Orlando. Lawanda, you made a great point with regards to placements being made for those who are so medically vulnerable and elderly from hospitals to a skilled nursing or assisted living. We recently had a case where a woman was very inappropriately discharged. She was 59. She has Huntington's disease, which is a progressive neurodegenerative disease, and is in a shelter, and clearly very inappropriately in a shelter because she requires a number of supportive services. And because we're in a non-expansion state, we face challenges with regards to placement because she has no entitlements. Her diagnosis she hasn't been definitively diagnosed because she requires genetic testing, which no one is able to pay for, and that was not done at the hospital. So we face a number of challenges in her particular case in terms of placement and finding her somewhere that would be appropriate to address all of the needs she has.
Thank you. And I think that many of the comments that are coming in through the attendee chat are really sort of around these same themes, that the requirements that to access nursing services and or assisted living may be impossible for some of the clients we're serving. People brought up in particular criminal histories or substance use and asked if you all have any suggestions for accessing services for clients who may be in those situations.
Yeah, so this is Lawanda from Baltimore. I have had some level of success, and this has been primarily around working with individuals who are in nursing facilities and in assisted living who are on Suboxone or methadone maintenance. There has been a little bit of a shift in terms of nursing facilities and assisted living being willing to work and partner with us around coordinating services and deliveries of those controlled substances to those facilities. So I think one of the things that we've seen is that we've had to be really active in helping that process to come about. And I think it's helped in a few of the cases that we've had more recently, I'd say over the last maybe couple of years, where, if we are playing a really active role in connecting that client's treating provider with that nursing facility and making contact with the social worker, we've seen that work best. But I think in terms of, one of the inherent challenges, I think, with the system is that, as HCH projects, we take on a harm reduction approach, but it doesn't mean the people that we're partnering with are harm reductionists. And so it's really about trying to be accessible to folks and helping to bridge those gaps. And that's kind of what we've aspired to do as we're, helping people to make that transition to skilled nursing facilities, whether it be for short-term therapy or longer-term therapy, to really serve as that conduit. Because I think it can be hard for clients to navigate that on their own. I think in terms of criminal justice involvement, the biggest thing that I've seen, and I actually don't believe that in Maryland individuals can do background checks. Now, that being said, I know that there are lots of ways in which, it's public knowledge and public record, and many of these details can be found out. But one of the biggest pushbacks that I've had in my career has been really around sex offenses and individuals who are required to register as sex offenders. I haven't seen a whole lot with people being excluded from nursing homes for, histories of I think violent crimes even, or drug-related crimes. It's really been, in my experience, around having to register as a sex offender, which has been the biggest barrier, I think, both for nursing home placements and ALF placements.
Thank you. Tia, anything you'd want to share about working with clients either who have been justice involved or using substances and how that affects their ability to access services?
You know, I really don't have a whole lot to add from Lawanda. I mean, we, again, embrace that harm reduction approach. But, you know, as Baltimore, we face some of those challenges where our partners perhaps don't. So, you know, it's education, advocacy, and we do the best we can.
This is Catherine from DC, and I share the challenge. We share the challenges that Lawanda mentioned in DC. I think that one of the things that we're trying to advocate for, as I mentioned before, is more sort of site-based or project-based housing that is more, I think of it as kind of like permanent supportive housing plus, that has a little bit more of the on-site nursing care that looks a little bit more like assisted living. The one thing I would say is that a lot of our patients, even though I may say, oh, this person needs a nursing home, in my clinical opinion, our patients may not want the sort of restrictive environment that nursing homes tend to impose, but they may be willing to be in more of an assisted living facility where they have their own private space where they can come and go and have guests and maybe, you know, do what they want in terms of, you know, drinking alcohol or using. So that's something that I think we're trying to advocate a little bit more for. It brings up an issue that we're going to touch on later, which is guardianship and how do you help to support or help make choices for somebody when they lack the capacity to make those choices to go into a nursing home. Because as we all know, most, you know, of our housed relatives don't necessarily choose to go into a nursing home. The family is the one who makes those decisions.
Thank you. And you all have all talked a bit about working with partners and the role that plays in advocating for your clients. Can you talk also about how you work to provide continuity of care for your clients, either once they're in housing or assisted living or, you know, whatever the service looks like, but how does that play a role?
Yeah, so this is Lawanda in Baltimore. So I think one of the things that we found really helpful as it relates to continuity of care is really trying to bridge the gap between medical providers either here at our shop or in the community and that new treatment provider. So if I'm thinking about it from a nursing home perspective, really making sure, and for us doing housing services, we're providing a lot of supportive services to individuals in their homes. And so when they become ill, have a hospitalization or something that warrants a transition to a nursing facility or an assisted living, you know, we typically will go out to that facility, interface with the social work staff, and I think the biggest thing is making them aware that we're involved and that we're interested in being involved and want to be helpful. Even with the challenges around there being a little bit of, or can sometimes be some divergent thinking around harm reduction and the ways in which we might approach other things that, you know, other people might find challenging. I think the thing that has helped has been for individuals to know that we are invested and involved and want to be consulted and want to be a resource. So I think leading with the idea and the intention that we desire to be a resource not just to the client but to our partner as well, and just trying to be accessible.
Hi, this is Tia from Orlando. Yeah, in Lawanda, you know, I think that's really key, that whatever, when we're dealing with these transitions in care, that whatever facility an individual might be going to, that they know that we are there 100% to support them and advocate for that individual. I've noticed with a lot of our elderly folks who have had repeated hospitalizations as a result of a number of chronic diseases, facilitating that discharge and working with discharge planners is really, really critical. So those discharges can be appropriate. So if they go back to permanent supportive housing or from a shelter to permanent supportive housing, all of the appropriate services are provided. You know, in Healthcare for the Homeless provide multidisciplinary care, and we want to keep those teams intact because we've established ongoing relationships with our clients. So continuity is really critical.
Hi, this is Catherine from DC. In Washington, we have definite challenges around the current process of housing because it's probably similar in most parts of the country, but permanent supportive housing, the support doesn't include medical support. It's really case management support that's not a medical case manager. And so what we're trying to work into our protocol with our continuum of care provider is a system whereby once somebody's matched to housing, the medical provider and the psychiatrist is automatically notified so that they can try to be part of that process of getting, once somebody gets housed, to write a referral for home health aid. And we're also trying to make sure that within the first 30 days of somebody getting housed, in addition to case management visits, there's a medical assessment which looks at, you know, whether or not somebody needs a home health aid, looks at what Lily mentioned earlier, does somebody need durable medical equipment, and makes sure that within that first 30 days, all the supports that somebody needs in their housing gets set up right from the beginning, including transportation. So how is a person going to get to and from their medical appointments now that they are across town instead of in the shelter or in the park where their provider happens to see them during the street rounds, and getting that, you know, in our case it's called metro access or the metro transportation form or door-to-door access, that sort of thing. But this is a work in progress, I should say. It has not happened, but this is our goal.
Gotcha. Thank you. I want to also thank all the participants who are typing in your comments and questions. And I want to point out a question to the panelists and also invite any attendees who may have suggestions for answers to respond as well. And that is, what types of funding sources support assisted living services? Bethany Benefield wrote that in Oregon, Medicaid covers a portion of the cost, but that the funds are extremely limited. Are there other funding sources in other places that anyone has been able to access?
In Baltimore, it's primarily Medicaid funding. It's much easier in our continuum. There's something called a Medicaid waiver here in Maryland. So individuals, the waiver wait list is closed for individuals that are coming from the community, but that wait list is open for individuals who are trying to exit a nursing home. And so there's under that Medicaid waiver, there's a living at home waiver, which is for individuals who are under 55 and under, that would allow them to be able to utilize that assistance to get housing in the community. And then there's also an older adult waiver through that same program that would pay for assisted living in portion. But one of the things that's always been sort of a challenge or an obstacle to that has been the fact that when individuals are enrolled in that program, they are required to relinquish a good portion of their income. And so if someone's getting SSI benefits, where in our continuum that is $771, a good portion of that is reduced such that that money goes to contribute to their care, and medical assistance pays the difference when folks are leaving a nursing home and going into a housing situation or assisted living. So I think oftentimes the idea of having to relinquish one's income can be a barrier, certainly one that sometimes people have a hard time getting over. I think in our continuum as well, there are some personal assistance funds that you can get, very minimal, through the Department of Social Services, but it's pretty limited. There are proliferation of assisted living type places here in Baltimore City, and it's been a little bit of a mixed bag. Generally, what we've seen sort of emerging over the last maybe 5 to 10 years has been sort of unlicensed places that will provide some assistance with basic daily living skills, certainly no heavy clinical, medically focused assistance, but someone who might need assistance with maybe bathing or medication reminders, so some of those lighter issues. There are some spaces for individuals to go, but the quality of those places, it's been a little bit of a mixed bag, and certainly they are not regulated by the Office of Healthcare Quality.
This is Catherine. Just we currently, to my knowledge, have no funds that support assisted living care. Medicaid will pay for nursing home level of care, and we have some very few site-based permanent supportive housing locations that are sort of senior housing focused, but those don't have any kind of centralized nursing function on site, so people can have home health aides visiting those sites. So in my experience, it's this kind of particular bird of assisted living, which has the kind of independence, a little bit of independence, but also the nursing care. So not quite independent living and not quite nursing home level of care is an in-between space that is not currently funded by Medicaid, and it just doesn't quite exist for our population in the way that I hope to see it exist in the future.
Thank you. And several participants are also writing in that giving up income towards paying for these services is a big barrier for clients to access, and that, let's see, in Minnesota, an older adult can use Medicaid funds to help pay for the services, but not the rent fees. So there sounds like the specifics may vary from place to place, but the commonality is the insufficiency of the funding that's available. I'm just reading through what's coming in. Let's pivot a little bit and talk about how your organizations and you in your work approach conversations about end-of-life planning, including advanced directives. How and when and who is involved in those conversations with your clients?
So here in Baltimore, here at our at Healthcare for the Homeless here in Baltimore, in our permanent supportive housing work, we certainly try to have those conversations with individuals pretty early on. Obviously, these are not easy conversations for folks to have. Sometimes they're not the first priority for people, particularly when we're first engaging them and getting them geared up to get into housing and focusing on that really quickly. But I think it's really important to take space to do that. We know many of our clients have people sometimes who they feel very comfortable with making medical decisions for them if they don't have the ability to do that. And then there are other instances where people don't have anyone. One of the things we see quite often is that clients who we're working with will want to designate us as the person to make their end-of-life care. And then we talk about these conversations, really trying to normalize it from the standpoint of empowerment. And I think that's been where my biggest successes have been, with engaging in conversations around end-of-life care and specifically doing advanced directives around this idea of being able to dictate how you want to see your life be and end, and that being within your control. and really talking with individuals about what's important to them and what matters to them and what makes for a dignified life and a dignified ending, and what would they want that to look like. With most advanced directive forms, there are a couple of different components. So there's a space on the form where you can talk about who you want to make a decision. And then there's another section of the form that talks about what specific treatments you would or would not want under what conditions. And so I've really thought about these two forms as, this form is two separate pieces. Here in Maryland, the standard form, you can complete as much of it or as little of it as you'd like. So for individuals who have someone who they would be able to identify as being the person to make a decision for them, but find it way too overwhelming at a particular point in time to think about the nitty-gritty of what specific treatments, whether you'd want to be artificially ventilated or whether you'd want CPR, to have a feeding tube or IV antibiotics and all of those things. If that's too overwhelming for someone, given where they are in their journey, then I might only focus on identifying who it is they want to make that decision and who do they trust, and making sure that that individual is aware that they are the one. But conversely, for people who don't have someone who they trust and feel would act in their best interest, then I really kind of spend a lot of time getting into the weeds of educating people around those treatment options, what they look like, and helping them to identify what they'd want if they were in a comatose or vegetative or in end of life and terminal, and really explaining to people what that means. So that's sort of how I've approached it in my work. And I think when I've done that, and I think all of this, oftentimes, of course, it's enhanced, and made better by the Therapeutic Alliance. But I think when I've done that, I've had some ability to help people either make decisions about what it is they want, or to at least identify someone who they felt could do that for them if they couldn't.
Hi, this is Tia from Orlando, and I think with some of the end-of-life issues and planning that we have worked on with clients, we've really worked kind of as a team, the provider, case management, peer support, behavioral health, in trying to discuss some of these really difficult issues, particularly those who have the best rapport with those clients. And I think some of the barriers that we've really seen, it really depends on when you start to address this issue. If this is an individual who's still on the streets, their prioritization is just meeting their basic needs for day-to-day survival. So, a lot of those individuals too might have some negative experiences with the healthcare system, and really lack of understanding what this process is and what do these terms mean. So, we try to shed light on a lot of these issues. We try to create a comfortable environment for some of these things to take place. And, we try to address some of the issues and financial barriers. A lot of these individuals have no insurance or are grossly underinsured. So that's kind of how we've approached it.
I would concur with both of the answers above. This is Catherine from DC. I think that it's a team approach, that we have case managers, we have providers. I think I would just honestly say that we probably don't do a good enough job. We don't address these issues probably soon enough. There are certain cases in which it's pretty obvious if somebody has cancer or terminal diagnosis, but I think that we need to do a better job as an organization of really having conversations kind of across the board with our patients who are older with multiple medical issues, and as Lawanda said, just to normalize it, that these are issues and conversations that everybody needs to have and start addressing. The one thing I will also mention is hospice, and I'm not sure what the situation is for folks in other parts of the country, but in DC we have a couple of hospice facilities, one of which is called Capital Caring, and they provide hospice regardless of insurance status, which is really fantastic. So they do accept insurance, but they also have provided hospice for folks who have no insurance. And they have we didn't actually have to do this, but there was a gentleman who we were caring for who was living under a bridge, and they said that they would come and meet with him under the bridge and provide, care for him in whatever capacity they could to the place where he was, because he was refusing to go anywhere else.
Thank you for sharing that, Catherine. And I'm curious to hear from others what sort of hospice services are available where you are that are accessible to your clients. And I see Bethany Benefield sharing that she works in Oregon, and they provide hospice, home health, and palliative care to anyone regardless of insurance or ability to pay. There also, through the chat box, several folks echoed the comments about having conversations about end-of-life decisions. Is a really challenging thing to do when people are facing the struggles of meeting their daily needs while homeless. And let's see, from Sherry Campbell from Chattanooga, they provide hospice care. That's fantastic. And then folks from San Francisco as well. Anybody else want to share about what you're doing where you are? And it sounds like in some places people are partnering with other agencies that will come to meet clients where they are. Please, everyone, continue to type in your stories and your responses. I wanted to ask our panelists also how you have navigated issues of capacity and autonomy and or guardianship with clients.
This is Lawanda from Baltimore. I would say, to be quite honest, not as gracefully as I wish we were able to. There is a very high threshold in our community for, incapacity and incompetence. One of, I think, the biggest things that I've had to do, on the program administration side of things is really talking about this distinction between capacity and competency. A person could be incapable, but also be very competent. Capacity is a very fluid thing. People can flow in and out of their ability to be able to make and understand the nature of medical decisions, and capacity is more of a legal term. And so I think navigating these things can be really difficult. We've had luck in engaging that system generally when individuals are either during a hospitalization or during a nursing home stay, to be quite honest. That's when we've had the most luck with getting someone's capacity or competency evaluated. I think it can be really hard as it relates to individuals who are living in permanent supportive housing, and I think, to segue a little bit, I think it can be really challenging for the staff who are working with individuals who see this sort of ebb and flow of a person's capacity. There are some days when people are doing really well and can understand what's going on and make decisions and understand the implications of action and or inaction. And there are other times where individuals don't seem to have that ability. And I think that's one of the things that's probably the most difficult for staff who are sort of in the weeds doing this work up front and personal day to day. And I think it's the thing that causes some level of, or can cause some level of burnout for staff. I think, it's been really interesting to see, it's a very difficult thing, because I think I can understand a person's desire to want to age in place. And, being in a position to advance an idea that someone is not able to continue to do that safely can be really, really challenging. As I said, there's a high threshold for competency in the state of Maryland. We've had instances where people have been deemed incompetent in our program and working with individuals. But I think there's also, this illusion that in getting that definitive answer around whether someone is, incompetent or not incompetent will change something dramatically. And I'll tell you, people still have agency. And so that's been one of the things I think as a program director, I've really struggled with, is really helping people to sort of understand that nuance and balancing this idea of personal autonomy and the fluidity of capacity, and then how do we manage when individuals are deemed incompetent but still have agency to make decisions about what they do and don't want for themselves. So it's complicated. I'd be interested to see how others have navigated that, particularly with staff, if there are other folks who are supervisors or leaders in their agencies.
Hi, this is Tia from Orlando, and this is such a difficult question, and I feel like we try to avoid these issues as much as possible, and what I mean by that is particularly in individuals who are elderly with multiple repeated hospitalizations. So those are usually related to frequent exacerbations of chronic diseases and even multiple incarcerations. We try to really work with the hospital staff and discharge planners on obtaining those capacity evaluations while they're hospitalized. And if a guardian, a guardianship is the appropriate next step, working on that process as well while they're hospitalized, because we don't have the resources, expertise, or funds to address those kinds of issues at our site.
This is Catherine Crosland from DC, and I absolutely agree with both Lawanda and Pia. We don't typically get involved with the guardianship issues. We have very few psychiatrists at our organization. We have 2 psychiatrists for 100,000 patients. That's not all people experiencing homelessness. That's our entire F2HD population. But I think the time, the resources involved in those kinds of legal issues, I think it's also in DC a really high bar to deem somebody incompetent or to lack capacity or competence. I need to hone up myself, Lawanda, on the distinctions between the two, but I find that often people are, for example, allowed to sign out against medical advice because they're deemed to be competent when somebody may have severe mental illness that we have seen on the street or
I think we may have lost Catherine. I bet she will call right back in. But I wanted to ask you, Lawanda and Tia, and all the participants as well, given the challenging nature of this work in navigating these issues and working with clients who face tremendous barriers, how do you all foster resilience in yourselves and your teams in order to continue in the work?
It's a challenge. I think part of for myself and what I hope to model for my team here is really this idea that one, the presentation in terms of what's happening in front of us, we have to appreciate the human spirit. And the human spirit, in my experience, tends to lend itself to wanting to be independent and wanting to have personal agency. And so when we are running up against challenges where a person is really maybe not able to fully appreciate or agree with the assessment that we as a provider might be making about their ability to live independently or be independent, and there's a divergence in our thought around that, I sort of rest back on this idea that people are doing and responding in a very natural way, because it seems to me that the natural thing is for people to want to have agency. And so I think if I consider it that way, it becomes less about like what's wrong with this person and me in this position of expert. Now, it doesn't mean that I don't have an assessment and, the benefit of, being able to have more of a bird's eye view and seeing what's happening in front of me. But it also prevents me, but I think that lens prevents me from looking at this in a very pathological way or in a way that sort of blames the client, but just seeing that behavior as a communication of like the human spirit. And I think when I consider it that way, it becomes a lot easier to sort of understand and appreciate where the client is coming from. And I think too, if we take our own personal stock, of our own lives and think about what it would be like for yourself. I mean, I think that evokes another sense of empathy as well. At least it does for me. So I think those are the things that sort of come to my mind when I see that. It can be really hard to transition. And we're working with a population of folks who haven't had a lot of agency, who haven't necessarily been seen, who haven't had opportunities to exercise free will, or, it's been challenging, especially when you start talking about individuals who have been just as involved for a while, and it can be hard. So I think understanding those things and just seeing that as a manifestation of a natural human response to something so innately part of you being threatened makes it a lot easier.
I think for us working with this particular population and trying to address some of the challenges, we've really tried to advocate and really in our community advocate for more supply of subsidized affordable housing for individuals who are elderly, because clearly if they do have income of any source, it's not sufficient to support them. And it's ongoing, our need to kind of identify what the issues are, how do individuals get to this point, and why have they lacked the support, and what can we do to change this. And I think for us those are kind of some of the ways that we try to cope and continue to work to address this issue.
Thank you both. I see that several attendees are typing now too, so keep going. And I think we have time for about one more question. So I wanted to ask, we have gotten into this, I think, in several of the previous questions, but what ideas do you have of ways your communities can do better? How can we better serve aging adults without homes?
I think that there's an opportunity for there to be some evaluation of the types of services that we have. I feel like there's not a, as people are dynamic, I feel like there's space for our continuum to be a little bit more dynamic. There are individuals who, and I think for people who are managing homelessness, chronic health issues, mental health issues, who are older, substance abuse is a big issue, and there's not a lot for individuals who are older, our aging population, people who are using substances. I think there's an opportunity for people to sort of recognize and be responsive with programs and services that really recognize the fact that substance abuse is the reality of some people's lives. So how can our systems be more responsive to this reality and focus on the reduction of harms for people who have made this choice, that this is their reality? And I think, you know, if we look to models that are overseas, and they're some in Canada, things like web assisted living, and really thinking about what place in our continuum something like that might have, where individuals are not kicked out, you know, if they're drinking, you know, and really thinking about how those types of environments might meet a need for a certain population. I think thinking about models, I think that Pia mentioned, we're really thinking about permanent supportive housing and having more nursing supports built in. We have tried really hard to write a nurse case manager into many of the grants that we have here for our housing programs, because we recognize that while we won't have enough nurses for everyone, our nurse has been really critical in helping us to troubleshoot really complicated medical issues. And so that has been useful. And I think thinking about this more creatively with some of those other models might be helpful.
Yeah, Lawanda, this is Pia. I agree. You know, I think really, and to educate our continuums on just the demographics of the elderly, knowing that the number of elderly individuals are going to more than double between now and 2050. I mean, that's an overwhelming statistic. And to really understand that, to educate our stakeholders, and again, to be able to facilitate better transitions in care for people who are elderly, providing care coordination, nursing support, as you had stated, and for individuals with disabilities to provide appropriate permanent supportive housing units that they can access easily. I mean, we've had individuals with walkers trying to get into second-story units, which is incredibly inappropriate, and we know that only increases their fall risk and subsequent hospitalization. So to work on some of those issues, to partner with our medical experts, our medical respite facilities, and, you know, I think ultimately our dream is to create something that's project-based for individuals who are elderly so that we can provide all of those supportive services under one roof.
Thank you. Thank you both for sharing your vision for expanded services and the way those services are delivered. I see participants have shared some other comments just about the challenges in navigating the current system and the need for more accessible, creative services, as Lawanda mentioned. Thank you all for the ways that participated in the chat today. We have great comments from everyone who's been involved. I think there's clearly a lot of need for conversations about these topics and to better support the people that we're working with and each other who are working in providing these services. So thank you all for being here today. Special thanks to Lawanda, Pia, and Catherine. It was great to hear from you all and about what's going on in your communities. You will receive a brief evaluation after this chat, so please all take a couple minutes to share your feedback so we can improve future sessions, and a recording will be available on our website within 3 business days.